How are you?
Trevor, how are you? I'm good, thanks. How are you?
Good. Yeah. I was just talking to the guys, so I kind of given a little bit of an introduction to what we're talking about today.
Yeah.
So they already know we're going to talk about combining dentistry with aesthetics, with a bit of orthodontics. So yeah, so we kind of know, we've set the scene. But some of the guys obviously don't already know who you are somehow. So if you can tell them a little bit about where you graduated from and then how you got to where you are at the moment, and then we'll have a look at some of these cases.
Sure. So I graduated in 2010 from King's College London, which combines three main London dental hospitals: Guy's Hospital, King's College Hospital, and St Thomas's. And so they kind of put it under the umbrella of GKT. And that was in 2010. I then did my vocational training, which is now called foundation training, I believe.
Yeah.
I did that in Buckinghamshire with the Oxford Deanery for a year. And then I continued to work there as a dental associate, working for the NHS for another just under a year. And it was a really long commute from home. So it made sense for me to kind of settle back where I am. So it was literally a 2-hour commute, almost morning and evening. So I settled in an NHS practice in Northwest London, in Dollars Hill. It was predominantly NHS. I worked there for a total of about 5 years. And then about 2013, I started doing very part-time dentistry in private practice. And then 2015, 2016, I made the shift and went straight to, and just started doing just private. And then kind of the niche of the practice I was working in was very much implant surgery. Yeah. But I was presented with the option of buying the practice, and you know, me being mainly cosmetic, having gone through my cosmetic dental training and facial aesthetics, I wanted to make sure that I could run that practice. So I changed the niche of the practice to a cosmetic practice. So bought the practice last year, just over a year and a half ago now, and yeah, so just doing private dentistry and facial aesthetics now.
Awesome. Is it just you in there, or is there a few other guys working alongside?
So my husband and I bought the practice together. Couldn't have done it without him. And he just does dentistry. So he doesn't do facial aesthetics, but he does a lot of kind of restorative dentistry. So tooth wear cases, full mouth rehabs. So it's he and I are the main full-timers, let's say. Yeah. And then we've got another associate, a hygienist, and some aesthetic therapists. But we're looking to expand our team a bit more in the coming year or so.
Yeah. I was very, very jealous of your husband's jawline and beard. So,
yeah, it's a good jawline. all natural, not my work.
No,
he was born with it.
You've not gone in there on an evening and jabbed him off or anything. So.
Not yet, but it's probably going to happen at some point.
Hopefully he's not watching, so he didn't say that. So we've got a case that I put up on screen. I think you're a little bit blurry, but guys, I hope you can see the actual case. Might just be the London internet. I always have a bit of trouble when I'm down south. But
is it a bit dark in this room? Is it just a bit dark? Let me just open the light, I think.
Try that. It may be pixels. It may be the pixels, but we'll try that. So guys, that was a little bit of an introduction onto who Zainab is and what kind of work she's doing. Drop your questions down below. I'll field any questions. We're going to try and keep them kind of related to the cases. Anything that's super specific, Zainab's going to should be more than happy to kind of address really, really specific things afterwards. You know, she's happy to kind of speak to you in the DMs and stuff like that. But we'll just go with a kind of an overview of the cases and drop in on those. So can you tell us a little bit about this lady who's up on screen?
Yeah, so this lady I saw in 2018. She came to see me. She's a model, and when she first came to see me, I thought, stunning. You know, what could we possibly correct here? This is my first impression when she walked into the room. But being a model, she was very aware of certain things that she discovered because of the lighting of being in shoots as a model, etc. So listened really carefully and found that, you know, her concerns had, it meant really that I had to look very closely at what to do here, because in all honesty, I couldn't see something very obvious to correct. And it was more about very subtle rejuvenation, freshening, and balancing, and just a bit of harmonizing. Now, if you start to really assess, and this is where assessment is really important, because yes, you have a first impression, but you must assess fully and really listen to the person's concerns. And although nothing warrants correction here, because nothing is severe, having listened to her and having assessed, what we can see here is that she's got a slight class 2 sort of relationship. And when I looked inside her mouth at her bite, she was indeed class 2. So she has an overbite and a little bit of an overjet. And we dealt with doing a bit of cosmetic dental treatment later. But at this stage, in order to give her a bit of harmony in her side profile, what she really wanted was to try and improve the projection on the chin, which I totally could see that a little bit there would make a nice impact. So what we have done in summary is enhance the projection and length of the chin. And in doing that, that's kind of given, because what happens when you give projection to the chin, you get a little bit more tightening of the jawline. So she's had sort of an indirect jawline enhancement, but no filler was placed at that visit on her jawline. And then very, very subtle treatment to the lips, but already she had beautiful lips. So it was extremely subtle. And this is why this is one of my most, I mean, this is not a quick appointment. This is really, really careful planning with a marker and going through it with her over and over again. And it's not about the volumes, it's more about very small amounts in a number of areas. So she had it in her chin to project, but also to lengthen. And how we lengthen the chin is we put filler in this area here. And that acts as a bit of a scaffold to de-rotate the chin downwards. So she's had a bit of lengthening as well as projection, which masked that class 2 relationship and just harmonized her profile, as well as a bit of lip enhancement that has done that as well. The cheeks, I don't know if you can see clearly here, but I've put a little bit of cheek filler. One of her main concerns was her tear trough, actually. And I was really convincing her that she didn't need tear trough. So my approach was, let's look, and the reason why we take that approach when it comes to tear troughs are more risky than other areas. There's a higher rate of complications. So of course, where it's warranted, where it's needed, we will treat it. But where there is very little need, we really need to look at whether the risk benefit. And in her case, she had a little bit of loss of volume just in this area here. Being quite athletic, she loses weight quite quickly as well, and she had a little bit of loss of volume here. So by enhancing that mid face, it adds a bit of support to the tear trough as well, and sort of just lifted her tear trough. So although she didn't have filler in the tear trough at this visit, she had an indirect improvement to the tear trough just by lifting it and supporting it to make it look shorter and less tired. So that was what was done at this visit. And I said, look, I will review in a month's time. And if we really do need tear trough filler, we will do it there at that point. And that's the best way, is always to look at enhancing the mid face, getting that support, and then revising whether we still need to do a little bit. And we did later do a bit of trickling of filler along the tear trough, very small amount. But if you go to the next picture.
Yeah, it's interesting you talk about the side profile and, you know, the projection of the chin. I don't know if you're familiar with an orthodontist from Australia, Derek Mahoney. He actually did an analysis with KEFs on the position of, you know, A and B across a whole host of models, and then he used that to then model his children's treatment. So he would aim for a certain A and B and, you know, cephalometric outcome to try and make the best aesthetic outcome as well as a dental outcome. So it's quite interesting that that similar sort of thing you've done with the planning there, I think.
Sorry, my sister was calling, I declined. So Yusra, if you're on here, I'll speak to you after. With what you're saying, absolutely. And this is where, you know, dentistry and facial aesthetics tie in really well together, and an understanding of skeletal development and an understanding of cephs and how to understand the proportions between the nose and the chin, where things should be, not just the skeletal and the hard tissues, but also the soft tissues. So what we do you know, when we take a photo of somebody from a side profile, we'll make a line from the nose, the tip of the nose and the tip of the chin, just to give us an idea of where the lips sit in relation to that line. And the lips should always sit just behind it.
Yeah.
We'll also, exactly, yeah, just to ensure that the lips are not overfilled. So we're constantly looking at that, and it starts to become second nature, of course, after several years of experience. But these are helpful aids. But once you've developed your aesthetic eye, you can spot this without the need for those different sort of records. Exactly. So looking at this front view, I mentioned that we gave her projection, and I also mentioned we gave her length to the chin. You can see that better here, that we've given her length to the chin. So in somebody who's class 2, very often there's that underdevelopment of the mandible, and the chin is shorter as well as retruded. So giving some length really helps with that. What it also does is it adds harmony when it comes to looking at where the lips lie. So, you know, I think in her after photo, having enhanced the length of the chin, her lips look less full, even though we've actually placed a bit of filler in the lips. When I say they look less full, the shape of the lips have been enhanced, but they generally don't stand out as much as perhaps they do in the first photo. And it's just because of looking at everything and how different features are relative to one another. You can also see from here that there is better volume in the mid-face, and that there is some lateral projection of the cheeks. So she's gone more towards a V-shaped, heart-shaped face, which she had anyway, but she's also a bruxist, and she has got masseters that are a little bit hypertrophic. So there's different approaches to dealing with this, but in her case, because there was a little bit of loss of volume around the cheeks, and because I was lengthening the chin, it worked well in that visit to enhance lateral projection of the chin, of the cheeks, elongation of the chin, which ends up being kind of the apex of the heart, and you get that shape. So that's what we did in that visit. You'll have another photo, I think, of tear trough.
Here we go.
So this is a month later, where I reviewed her, and she's got, you know, the nice shape of the face, but the tear troughs were still bothering her. And again, it's not a massive need, but it was really still bothering her. So a little bit of filler was put there. And I'm very conservative about under eye treatment, because under eye area is an area that really attracts a lot of water. So one of the complications is swelling and edema. Which can sometimes, I mean, it's uncommon, but it can be quite a tricky one to treat, and it's quite persistent. So the approach here is always to take a sort of a less is more approach. So when we do tear troughs, we never do 100% correction. We go for a 70% correction, with the aim that over a 4-week period after, there will be some water attraction to the molecules. So the hyaluronic acid is hydrophilic, it attracts water molecules, and you get a bit more volume. So this is immediately after, but she continued to have improvement after. But you can see that there is a reduction in the length of the tear trough, and it just looks slightly
a bit softer.
I'd say less tired and just a bit softer, yeah. And that's the goal here with somebody already attractive. What do we have next?
So we have a kind of a lateral view, I think.
Right, so here it's, yeah, so this is an example. This is actually more recent. So this is just another view to show how this, here what I'm demonstrating is that, again, fillers are not permanent, so you lose the volume after a while. So when she had her retreatment about 2 years later, she needed it around this area. So if that angle there, so if you go to your next after photo.
You can see it really nicely there, can't you?
Yeah, so you can see the curvature, and we call this the OG curve. It's the zygomatic eminence, and that's a key area for women to have a little bit of volume, so you have that nice feminine curve. And what it also does is just help to rejuvenate the tear trough a little as well, in an indirect way. So she's had that done here, as well as a bit of tear trough. So go back one again. So
here we are.
So you can see the tear trough there, and then if you look again at the post-op, tear trough just looks a little bit healthier as well. So combination, okay? So it's just a little example to show how rejuvenation can be done, but in such a subtle way.
Yeah,
and then
it's kind of Ismail was saying the face and nose looked more symmetrical afterwards, as well as kind of adding the length to the chin as well. So That's kind of the balancing side of things, isn't it?
Exactly, yeah. So there was a bit of balancing we did on the lips, but also the chin. We've always worked on her chin balancing, left to right. Here is just neuromodulation. So this is botulinum toxin in the orbicularis oculi muscle to treat the crow's feet lines, the dynamic crow's feet lines. Yeah. So the results are not immediate. They're 2 weeks later, and you can see here that she's got, when she's smiling, there's just no lines. And you can also see that, can you see that the eyebrow has lifted? Yeah. Slightly. Well, from a female point of view.
Now you pointed it out.
So she's got very subtle eyebrow lift. And why that happens is because by injecting that muscle with botulinum toxin, you're cancelling out the effect of the muscle, which is a depressor muscle. So you get elevation because the frontalis activity overtakes. So that's how, so by releasing just a wedge of that muscle, you get a release of the eyebrow. So this is a nice treatment. It's just it was an adjunct for her. Later down the line, Amira had her teeth, she had composite veneers, but then she has had bruxism for a long time, but no obvious interferences were found. So I treated her bruxism with Botox in the masseter muscles. And what that does is, so by overgrinding the muscles, by overgrinding this muscle, that masseter hypertrophies, and this causes a widening of the jaw, which in a female can be less aesthetic. And so in order to narrow that jawline down, just treatment of the masseters over, and then 6 weeks later you see the results, and it just a little bit of slimming as the muscle just atrophies a bit. So we did that. Now, one thing that has to be appreciated when we do that treatment is that, think about the muscle, when it's hypertrophied, it's a little bit of extra mass inside the face. So it's adding support to the skin. When you treat it with botulinum toxin, you get a bit of atrophy of the muscle, right? That's the goal. But in doing that, you get less support of the skin. So the skin can get a little bit more lax. So if you look here at the before photo, what I'm showing here is that this is after her masseter treatment, about 2 months later. And just there is that definition, loss of definition along the jawline, which I had exactly. And this is why it really took her 2 years to decide to do this treatment, because I always warned that this might happen. And I love her jawline, so there was always that you know, that might get compromised, so you lose that definition a little bit. But the pain she was getting and the tension, especially in the mornings, warranted, you know, and justified that treatment. So we did it, but then what we did after is enhance the jawline again. So I don't know if you can see, but there's the angle of the mandible is a little bit more defined in the after photo. So that's just treatment along the board of the mandible and just at the angle and a little bit on the ramus, and you get that nice little bit of definition.
Was that immediately post-op?
This is immediately post-op.
So would it kind of smoothen itself out over time?
So the reason why it can look a little bit proud on day one is because you have to place this filler quite superficial, because the facial artery lies deep. So by avoiding, you have to try and avoid the facial artery. So you go with a cannula and you have to go superficial, but then you have to appreciate that you're going to get a little bit of product that you can see, and you immediately mold it. And then as the swelling comes down as well over the next few days, really, that definition is just much smoother and it's less obvious. So this is not very long ago, probably about just not long before lockdown, maybe about 2 months or so before lockdown. And it's still there, and we speak often. And yeah, she's a wonderful patient and become a friend now.
Any side effects on that?
She's always gorgeous before and after. Sorry, say that again.
Any side effects? Got a question asking.
Yeah, so absolutely. So the side effects, well, there are risks with any injectable treatment. Ultimately, we're putting a needle into the skin. We're bypassing several layers of anatomical structures, and we have to consider different things that can happen. So one of the most common things is swelling and bruising. And with swelling, it's usually, in the vast majority of cases, not severe. It's a minimal amount of, I would say, teeny bit of puffiness, and you could say it looks a little bit proud. So it's slightly over projected on day 1, day 2, maybe day 3, and then things start to settle. Very few patients might have a lingering swelling for up to a few weeks, but everything settles. Same with bruising. So the average sort of bruise will last about 7 days. People don't always bruise. In fact, the vast majority of the time people don't bruise, but it's always possible. So those are the common things. And then of course there are uncommon risks, pigmentation, allergic reaction, infection, late onset nodules, which is like a delayed sort of immune response that manifests as lumps that can come up weeks or months later. It's very uncommon, and it's more common in people who have an autoimmune condition or some sort of reason to have an immune trigger to create that over time. And it can be treated. And then there's the 3 very serious risks, but very rare. And one is necrosis. And necrosis is essentially, as you know, death of skin tissue or death of any sort of soft tissue or hard tissue. Necrosis happens because of vascular compromise. So if you get filler into an artery and you cause an occlusion, you know, skin cannot survive. So that becomes an emergency. And so we're always talking about this with our patients, and I tell my patients to look out for the signs. They have a direct contact number to me in case. I've never had one happen, but I'm always ready. And the minute that you think that there is a vascular compromise, you've got to dissolve that product to resume blood flow and prevent impending necrosis, and know your anatomy in order to try and avoid it in the first place. But the other risks, and this is something not everybody knows about, and really they should know about, and we always explain this in consultations, but I think sometimes it's overlooked in the culture of social media, where, you know, there's so many photos of before and afters, and I feel that it should be talked about a little bit more. And they are the very serious but rare risks of blindness and stroke. So that's important to be aware of. But they are very risk. It's very rare. It's sort of a risk of about 3 in a million.
Yeah, it comes down to that kind of, you know, when you get a packet of paracetamol, there's a little piece of paper in there that lists a whole load of things. A lot of things that may happen, but are very, very rare. 99.99% of the time, you'll be okay. Rena, if you're after price list, please DM Zainab afterwards. I think that's probably more suitable to the DMs. And Ismail, are you talking about this case that we've got up on the screen now? Should we talk through this one? I think he's asking about this case. Only with fillers or any surgical.
Is this about this case? So just to clarify, Amira did not have any fillers in her nose. So that's so she's not had any treatment to her nose at all. That's her nose. This case, non-surgical, completely non-surgical. She's had no surgical treatment whatsoever. So this is a very lovely, very wonderful patient who it just really lights up my day when she arrives. She travels a long distance, and this is on her first visit, and then the after picture is she's had, I mean, I've been seeing her for a few years now, so this is probably the most recent photo, the after photo. So this is a progression, and this is the before and then after several treatments. But on day 1, even, she had fantastic results, and really it's just been upkeep and maintenance. So what we've done here is, if you look at her before photo, she's got the dorsal hump, and she complained of a slightly droopy tip of the nose. And the aim of non-surgical rhinoplasty is, because it's non-surgical, you cannot remove tissue. You're adding volume in areas where you can feel a depression in order to mask the dorsal hump and elevate the tip and correct some of the angles. So here, the depression is the radix here. And by adding filler right on the periosteum after aspirating and really carefully, you get projection of that area and an immediate disguise of that dorsal hump. On the tip of the nose, you have to be even more careful because it's highly vascular. The tip of the nose, we look for the highest point on the tip of the nose, and this is all marked out before we touch the patient with the needle. And small micro aliquots of filler are placed, again, deep on cartilage to try and bypass the important vascular structures, and after aspiration. And what that does is, again, just add projection to the tip and elevate the tip. in her case, it wasn't, I mean, if you just add on the very tip of the nose, you then have what we call a super tip break, which means that we've added here, but we've now got a little kink just there, right?
Yeah.
So that then is the third point that I fill. There's this fourth point I think she's also had, which is this point here. And by adding filler in that point there, very deep, literally on the nasal spine,
yeah,
you get further upward rotation of the nasal tip, and an increase in the angle here, the nasocolumellar angle. But that has to be very deep again, because the columellar arteries are superficial, so you bypass past them. You've got to be on bone and at the right angle. And again, with everything here, less is more. And this is why, you know, and my patients know this really well, is that I would rather do small amounts and do it over a number of visits where I'm worried about safety, or where I think that enough is enough on that visit, rather than do everything in one visit. And that's especially important when we're talking about the tip of the nose, because it can be quite a tight area. And you don't want to put too much product and end up with too much compression and cause sort of an indirect vascular compromise there. So less is more in that area as well. Now what we did after that is the chin and the lips. So when we look at profiles, you know, you can't look at one feature in isolation. They all tie in together. And again, this is where, as you very rightly said, by looking at all those other records, you begin to understand, you know, where the features should lie in an ideal situation. And so you aim for that to achieve the nice harmonious balance and a nice aesthetic outcome. So what we've done here is projection of she didn't need elongation of the chin. She's had projection only, and lower lip. And if you look at her lips, I'm very, very mindful with her that she's got actually quite full lips. But why I felt that, and she felt that there could be room for improvement at the lips, is just because, again, once you do the nose and you do the chin, things change. And the lips then tend to have more, and they tend to then have more room for projection. So I'm really careful with her upper lip. I hardly ever do much on her upper lip. I focus more on her lower lip, because actually I don't have her front view here, but when you look at her front view, her top lip is fuller than the lower lip. So you always want with lips to have a balance of about 7 to 10, where the lower lip is fuller than the top. So that's what I'm trying to achieve here. So she's just over the moon, and this is why she's wonderful. Every time she comes, she's always sending lovely messages. And again, she's become a friend. And this is what I love about these treatments, because you see patients, you know, over a period of time, you know, routinely, every 6 months, every year, you build relationships.
I believe it's called a Jefferson analysis, where you're working out where these little areas should be from your calf. So if someone wants to look out for that, if there's some students out there doing, you know, finals, that's a really interesting one you can kind of pull out in your ortho. I think that was a lot of the aesthetics that you gave us, wasn't it? I think we had now some. How long does it take, you know, for things to wear off and you have to top up, actually, as I'm asking?
Yeah, we can take some of these questions regarding aesthetics. How long do these effects last? How frequently does it require topping up? So this completely depends on two things. One is which filler is used, and two is which area it's placed. So the lips, for example, are a very dynamic area. And because they're very dynamic, there's a lot of blood flow, and the filler is more likely to break down quicker. So in the lips, an average sort of time is about 6 to 9 months. On the nose, however, it's not dynamic. So filler tends to stay put for much longer, because it's not dynamic, and also because the density of the filler is much higher that we use in the nose. So we use a much thicker, much more viscous product in the nose, because we're really trying to mimic bone, really, or cartilage. We're really trying to mimic a thicker structure here. So you use a more viscous product, which takes longer to break down. So in the nose, it's about 12 to 18 months. Same with the chin, about 12 to 18 months. Tear trough, very, very light and very minimally viscous, low density filler, and lasts about 12 months.
Yeah, perfect. We actually had
because
two
it's
more
not
cases.
Dynamic again.
Yeah, we actually had two more cases you sent me right at the end. I just remembered.
So this one here, okay. So here's another lovely lady who I saw not long before lockdown. and she's had non-surgical rhinoplasty and chin projection. And she's had these both done in one visit. This is the immediate after. And again, it's treatment to the radix to enhance the projection there. So high density filler placed supraperiosteal and on the tip. I don't think she needed much on that supra tip break I mentioned. That third point, I don't think she needed that, nor I don't think she needed that one either. So this was a 2-point rhinoplasty, and beautiful results. And whenever we do these treatments, you know, you have to kind of visualize the result before you even start. And that's how you plan it. The chin, we did some projection, but we're planning to do more projection. You know, because she traveled a long distance, she wanted to do both on the same day, and because it's her first time having fillers, she was also a little bit cautious. So it's that balance. So we did both treatments, but allowed her to kind of get used to the idea. And now in future, very likely we'll be doing a bit more projection on that chin. But already she's got a really beautiful balance there. It's absolutely stunning girl.
Yeah, you can see instant kind of changes once you've done these, and once it settles in, obviously it improves over time as well. So this is one where we've got 1 year follow-up actually. So I thought it was quite interesting. You can see how it's changed over time. It actually looks a lot sharper after a year than it does, you know, straight afterwards. So it kind of matures in a way.
Yeah, exactly. So what happens here is that although the filler itself may break down, you get a little bit of collagen synthesis as well, because you've had a degree of trauma, having had a needle or a cannula placed inside the tissues. So there's always going to be that small amount of collagen synthesis. But also, actually, we find that the filler doesn't go away within 12 months in a lot of patients, on the nose particularly. And this is a big plus, a big bonus, because it means that every repeat treatment, you'll need less and less product, which means less and less risk, and also less and less frequent. So it does get to a stage where you almost don't need much more other than a very small tweak to maintain that shape. And this is, so that photo, that after photo is, I'm not sure actually, is that immediately after her first? Yes, I've said first treatment. So that's after her first treatment. And then a year later, we didn't need to put very much more in, but we achieved a little bit more tip elevation. So she's got a little bit more of that Tinkerbell tip on the second treatment a year later. Why? Because now I'm not as concerned about putting too much filler there, because I've already allowed that filler initially to integrate. And now adding a little bit is reasonable to achieve that next sort of step up and get that even better aesthetic result.
Yeah, it's like
she's also had lip treatments as well.
Yeah.
She's also had lip treatment, and in her case it's the opposite. I've worked more on the upper lip rather than the lower, because if you look at her lips, the before, she's got under projected upper lip compared to the lower. So just a little bit of harmonization there, give her a little bit more of a better proportion between upper and lower. And that works well with, you know, the new proportions and then her nose as well.
Yeah, I think that's a really nice example of kind of a long-term follow-up as well. So the guys can see how it looks over time, because I think some people may be worried that, oh, I'm going to be in every couple of months, but sometimes it's actually quite, you know, a long-term result, and you're just tweaking things and making it just, you know, a little bit sharper each time.
Yeah, absolutely. And it's the same with the lips. You know, after having had 1 or 2 treatments, it usually, I mean, this is for many people, but not all. Some people really, I mean, it's almost like the lips drink away the filler very quickly. But it tends to happen in people who are very athletic and have a high metabolism. But in many people, it's something you can build on and build on and build on over a period of time, gradually, to achieve the sort of shape you want. Never too much in one visit. It's all about staging it in order to gradually distend the tissues and not stretch them in one visit too much and end up with lumps and unsightly sort of stretched tissue.
But and in terms of lips as well, we spoke to Thoha a while back, and she said that she prefers to use a cross-hatching method as opposed to a direct, you know, just squirt it in the side and let it kind of blow up. Is that the correct way, and is that what you would advise as well?
So with lips, there's so many different ways of doing lips. It's a bit like how do you skin a cat, right? So it's a very artistic thing, and each injector will have mastered their own crafts and the way that they achieve their results.
Yeah.
Over time, I have varied my technique as you kind of build upon it and build upon it. And it's really important, especially with lips, that once you know that you've developed a technique that works well for you, and you know that you're going to achieve what you're planning to achieve through that technique, that you don't necessarily try and change it, because there is no gold standard way of treating lips. There's a variation. For me, I think that's a nice technique that Goha does, but for me, what I do is I do linear threads to begin with. This is how I was initially trained. Yeah. But then I've also now sort of tweaked and modified that to work for me and what I really want to achieve, given all the experience, you know, over a period of years. So what I do is I start with a linear technique, but to minimize trauma by being in the body of the lip too much, I do sometimes do vectoring, and you get really nice. And vectoring essentially means you're going from the vermilion border in, yeah, but not as deep in, yeah, and a little bit more superficial. And you get a little bit more definition, and I find you get a little bit less swelling. But this will vary, for, you know, between patients. So I'll give you an example of where I might choose to do one method over another. If somebody has got very projected vermilion border, very well-defined vermilion border already, if I did the vectoring technique and I'm going from the vermilion border in, they're going to have an overprojected, potentially overprojected vermilion border, particularly if you inadvertently deposit too much in the vermilion border. So, so a patient like that, I'll stick to the linear method. Yeah. When I'm talking about the lower lip, I like the linear method, still my favorite, but I've modified it such that when I'm doing that kind of, I try to achieve the medial 2/3 of the lip to drop down a little bit more. Yeah. Because that's how the light sort of reflects nicely on the lip. To achieve that, I do some vectoring in sort of a V shape and a number of layers. So my way is minimize trauma as much as possible, because lips do swell. But again, there's so many ways, and they're all wonderful ways, as long as you know how to tackle it. As long as you know how to tackle it and get the results you want.
Yeah, I think it's just interesting, because I've spoken to a few people now, and everyone seems to have a slightly different take on it. But I think everyone's kind of saying the same thing. It's a little bit of both. Yeah. You just don't want, you know, a huge amount in one place, because it's really obvious, and you know, that's when it becomes puffy, as Raynara is saying in the comments there.
No, exactly. But that turns out to be, in a way, a bit of a crosshatch, because when you're doing a linear technique like this, you're doing linear thread like this, and then when you do another one in that direction, you're going at a perpendicular angle to that initial thread. So in a way, it's crosshatching, but I wouldn't do it throughout the lip. It's just in different parts of the lip, depending on what I'm trying to achieve.
It depends on the patient and what they present with and how you want it to look afterwards. And it's just same as kind of if you're doing a veneer, masculine tooth versus a feminine tooth, you know, there's a different characterization there.
I'll tell you where cross-hatching does work well. It's where you've got real defects. So you've got a real depression in the anatomy. So I tend to do cross-hatching quite a bit here in the marionette area, because you get a depression there that you need a bit more of a layering technique at different angles to build that scaffold and plump up and get that projection and that lift. In the lip, the only place where I do a little bit more of a crosshatch is where you sometimes have a defect around this area. So the lip is almost in a curly, it's almost in a curly shape, where you have a bit of a drop down in the middle. You have a deficiency here, sometimes referred to as the M lip. That's an area where a little bit of crosshatch works very nicely.
Yeah, awesome.
So just, you need to vary it. Yeah,
I think that's answered it brilliantly there. So we'll look at one dental case as well, because we've gone right in detail on the aesthetics side. I think this was a nice one.
Sure.
I think this was a really nice one, actually.
Yeah. So this is a case. Lovely girl traveled from France to have Invisalign, and it took her probably about 4 or 5 months. So she's had upper and lower Invisalign treatment, and then teeth whitening. So in the last phase of her Invisalign, she will have been given whitening gels to use inside of the Invisalign trays. So she's simultaneously finishing off that last phase of straightening as well as whitening at the same time. So by the time she's back to see me and has finished her final aligner, she's also got the white teeth. So white straight teeth, and we're at that stage, we're doing our contouring, recontouring with composite. So this here is a before and a final after. So she's had the bonding here as well. I don't know if I've sent you any other images. Okay, so they're all before and then final after. But in between, what's happened is once they were straightened out, there's been some contouring with composite bonding. So the approach here is align the teeth, get them in the right position, whiten them, and then do fine tuning with composite, which is where really all the art happens and all the magic happens, and you get that wow, you know, factor on the day.
I think we had an oral one as well. That's the same case, isn't it? Yeah.
So here I think you can see a bit better that we've widened the arch as well, so corrected the upper and lower crowding, and we've widened the arch, which is important to kind of reduce those buccal corridors and get a wide looking aesthetically pleasing smile. In a case like this, you can see the two centrals have got different lengths. It's partly because of the rotation of that upper left central incisor that it looks like the upper left is longer. But in some cases where you have different lengths, we look at whether we're going to align the lengths or align the gums. I think that's going to be demonstrated actually in the next case if I've sent you it. Did I send you another?
We've got absolutely loads. So that was that one there. Was this the one you were
talking
about?
Here's another. Yeah, so here, go to her very before. And now there's another image, I think.
Let's have a look.
That I should have sent you.
Is it this one?
There. Perfect. So this lovely patient has had fixed orthodontics, and you've got different lengths of, so she's got class 2, div 2 incisor relationship, and she's got an increased overbite, and so the aims of treatment here are relieve the crowding, so align the upper and lower arches, reduce the overbite, and looking at the two upper central incisors, there's a difference in height between them. So here's the question of, do you choose to align the edges, or do you choose to align the gums? And that's always a conversation to have with patients when you have this situation. And in this case, because she's got a high lip line, when she smiles, the gum area may well show. And so we chose to align the gums, keep them aligned, and leave that difference in the tooth heights. So if you now go to the previous photo you showed me, no, the one before that, this one. So you can see we've aligned all the teeth, but her two centrals are still not equal in length, and that's where composite bonding helped, as well as recontouring, giving her a bit more width to the smile and getting all those proportions nice and getting the embrasures nice. And this is where the art happens in that last stage. So yeah, this is a really lovely stage, and this took about a year. So she's had a reduction in overbite as well. I think there's some more images where you'll be able to see the side profile, and you'll be able to see that a bit better.
Yeah, so this was part of the same case as well. Interesting question. Are you someone who's working with a lot of digital technology when you're doing these smile design cases, or are you working more of wax ups from labs? What's your approach there?
So we have, I use both. So where I'm doing Invisalign, we now use our iTero scanner, which is a digital scanner. But where I'm using, I mean, we've always got the option of using the iTero scanner, but I predominantly use it when I'm doing the Invisalign treatments. A lot of my patients who are anxious about having impressions in the mouth or have gag reflexes, they'll want to have the iTero scanner for any treatment, whether it's a wax up or a crown or whatever, and that's absolutely fine. So we have both, and I use both.
Seeing as you're using both, do you find there's a difference between either? Does something kind of, is there any limitation with the iTero at the moment compared to a traditional technique, do you think?
I'll tell you my experience of it. I think it's great. I think patients love it. I think it really ups your game, and that, you know, as the more you get into digital dentistry, the more exciting it becomes, because dentistry is just going in that direction. But I find that impressions are still a bit quicker. So the iTero scanner just takes a little bit longer to make sure, because you've really got to make sure that you're accurate and you've got every single nook and cranny and every corner of every tooth recorded.
Yeah.
So you do it, and then you have to sometimes redo some areas until you get it. So it takes probably about, on average, about 10 minutes for me. An impression will take about 5 minutes. So it's just that factor, but I think it's great. I think it's the way forward, generally, broadly speaking.
And the machines will get better, so the scan time will become more kind of favorable, but you don't see much of a difference in the kind of quality of the outcome of the models that get printed up or anything along those lines.
I haven't seen that, but I think that's probably because I'm using it more for Invisalign, and so it's hard to spot. Whereas if you're using it a lot for crowns, you'll be able to spot that. So maybe ask me in a year's time. But for now, it's mainly Invisalign that I'm using it for, and I'm not seeing issues with that at all. I think, in fact, it's better because it's easier to reach sometimes those distal corners that sometimes get a little bit missing on an impression.
Yeah, I think that's kind of I would prefer to use one if my practice had one. Obviously, it might be 2 years. We have to ask you if we actually do any real dentistry by the next year. But going back to the photograph on screen, we're just looking at the side angles as well. So the kind of the lateral views. So you can see it's been a really big difference, and you can see the after alignment and then after the bonding as well, which is what you were pointing out before I went off on a tangent.
Yeah. So again, this is aligning, repositioning all the teeth, correcting orthodontically, whitening, and bonding. So it's that align, brighten, and bond case again, except it's fixed orthodontics, not Invisalign here. Took about a year, but this photo just shows quite well that we've also reduced the overbite. So I don't know if you can see that. And she has small lateral incisors, so either way I always knew that bonding would be the final, would have to be involved in her final finish to get those proportions perfect. But this is the kind of case I enjoy doing, and this is what really gets me going. It's that you can see it when you see your before, you see your patient, and you've taken your records, your photographs, etc., and you just start visualizing what's possible. And I'm always kind of like, I can so see where we're going to be in 6 months or a year. And it just makes the whole journey really exciting. And as we're getting towards the end of the orthodontic journey, we both get really excited about that bonding visit, because that's literally where I think the magic happens.
Yeah, I think that's kind of like when you have that correct sort of passion for the treatment that you're doing, that leads to people coming from France. It leads to people moving, a large distance to come and see you and have that treatment done. So I think that's the old adage where people say, oh, you've got to do what you love. And I think that's just, that shows, because then you can progress so much faster because you're enjoying what you're doing and you're really interested in all the little bits and pieces. So yeah, I totally agree there.
Yeah, you've got to be passionate. You've got to love what you're doing, but there has to be a driving force, a why. You've got to like it for a reason. For me, it's a combination of things. Number one is that these are minimally invasive in that we don't do any drilling of the teeth, right? So this is a huge transformation for this lady without any damage to her teeth. So although she could have arguably had faster treatment with porcelain veneers, she would have had a huge amount of destruction to those laterals. The bite is not ideal. You would never have got a really great result with the lowers, with porcelain veneers, without massive destruction to those canines. I mean, it's just not something I would even really entertain. So minimally invasive ethical dentistry involves looking a bit more at the long haul. What can we do here to get the teeth in the correct position before any restorative work? And so that's one of the main things for me that really drives me towards this kind of work. And then again, it's the fact that I can then get my artistic flair out, and it satisfies that, I really love art at the end. Yeah, exactly. So I love to sculpt. So that's what really ties facial aesthetics and dentistry together for me, and why I love them both. So these are what I really love about these sorts of treatments, and this is the way forward. Everybody wants to have safe treatments, and I think this is why people travel a long distance, is when they can see that you're able to achieve these sorts of results with no destruction or minimal destruction in a safe way. But it means the world to me when patients travel that far. I mean, especially for something like Invisalign, which involves so much back and forth. She's a very special patient.
Yeah, and I think even if you were to go down the route of porcelain veneers, me and Erzim, who's in the comments there, we were at a lecture in Chicago not so long ago where there was a guy who's at the top of his game in that kind of treatment, and he wouldn't touch a case like that until after orthodontics as well, because he wants to do as minimal kind of removal of, tooth tissue when he's doing his veneers. So
Exactly.
either way, in a case like that, it's not something where you can just slap on a crown or a veneer and say that's a job done, because that kind of treatment is the treatment that fails and gives veneers and crowns and composites a bad name.
Exactly. So yeah. And sadly, there are some schools of thought that would be okay with doing that, and I know much older dentistry would have maybe gone in that direction. And some parts of the world that's still probably very commonplace, actually, that that will be the go-to treatment, but certainly not. I mean, the UK dentistry, we're a lot more about minimal intervention and safety, I think, and we're going the right direction with that, and we have been for a while, and I'm so glad to be able to do that.
Yeah,
I wouldn't be able to sleep at night drilling healthy teeth down too.
Yeah, I think it's one of those things that you have to make the patient aware, and I'm kind of in the camp that I'm probably on the fence more than most people, because I've had quite a lot of exposure to everything. But even for me, a composite bonding case is not irreversible. It's an irreversible procedure, so I want guys to know that when they go ahead with it. So but it is obviously so much less destructive because it's an additive process.
Absolutely. Yeah.
A question, really good question actually here from Erzim. Surprisingly, he's still with us. He's really interested in facial aesthetics. What courses did you look out for when you were starting? Which ones really helped you out?
Right. So I started out 2013 with facial aesthetics, and I did a basic foundation course first. And then from there, I built on that with an advanced dermal filler course and advanced Botox course. And I think probably if you want specific names, because there's such a wide range I've done that I wouldn't know where to start with naming them. I mean, starting with Oris Medical, and then I've done with Academy 102 in Harley Street, Allergan workshops, so many more. Sabrina Shah Desai, who does anatomy and cadaver training, which is a real must, quite early on in your, especially if you're doing lots of fillers. Cadaver training, to really know the anatomy very well, is key, and being able to manage complications, it gives you so much more confidence. So complications course as well. So I literally have a whole list I've put into previous presentations for people who are really interested in this. But it's a journey, and my approach has been not to dive in. I mean, it's been 6-7 years now, not to dive in and try and learn everything in a year. My approach has been master one area of facial aesthetics really well, and then go on to the next, so that you never feel like you're drowning, and so that you've really understood how to tackle that area before you go into the next. And that's how you build on your knowledge, and in a way that you've consolidated properly and mastered it properly. So that's my approach. That's kind of what I tend to advocate, that people do it very step by step. Non-surgical rhinoplasty and tear troughs came later. So I started with the basics, and then riskier areas of the face would be a bit later, so a couple of years later. And I started teaching in 2014, which again for me was a really lovely part of my journey, because once you start teaching, it throws you into really understanding your subject a lot more, because you're teaching it. You've got to be at the top of your game. So when I started teaching, I really threw myself also into a lot of training, and I've continued to do that. And now I'm a bit of a course junkie, where I'm addicted to courses, and it's a non-ending journey. And that's the beauty of it. It never gets boring, because there's always something to learn.
Let's just end the live here. We've got about 1 minute remaining. We'll do about 5-10 minutes of just answering questions if we have any, just so we don't get cut off halfway through answering something, just because it seems a bit cleaner that way. So we'll jump back on in about 10 seconds. Okay,
that's fine. Sure.